Good afternoon and welcome. Thank you for joining us today for our Alumni Networking and Education Series event on safer use of opioids for pain, emerging evidence for the pharmacist role. My name is Tara O'Leary and I'm the Manager of Alumni Relations at the Leslie Dan Faculty of Pharmacy. Before we start our event this afternoon, I'd like to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of Indigenous people and remains home for many Indigenous people across Turtle Island. We are grateful to have the opportunity to work on this land. Today's webinar is part of our Alumni Networking and Education Series brought to you by the Office of Advancement at the Leslie Dan Faculty of Pharmacy. The series provides you, our valued alumni and friends, with relevant, thought-provoking presentations and discussions on current hot topics in pharmacy and pharmacy practice. I'd now like to welcome our speakers today, who both bring a wealth of knowledge and tangible lessons in the role pharmacists play in safer use of opioids for pain. Dr. Beth Sproule is a clinician scientist at the Center for Addiction and Mental Health, CAMH, jointly with the Leslie Dan Faculty of Pharmacy, where she is an associate professor and cross-appointed to the Department of Psychiatry. She received her Doctor of Pharmacy degree from Wayne State University, Detroit, and her Bachelor of Science in Pharmacy degree from the University of Toronto. Dr. Sproule completed a clinical residency and a postdoctoral research fellowship at the Addiction Research Foundation, Toronto, now part of CAMH. Her clinical research program focuses on medication use disorders, mental health medications, and pharmacy practice. Dr. Sproule will be joined by Dr. Laura Murphy, who is a pharmacist in the Comprehensive Integrated Pain Program and a pharmacy clinical leader at the University Health Network, UHN. She is a member of the expert advisory panel of the Canadian Pain Task Force and Project ECHO Ontario Chronic Pain, and co-chair of the University of Toronto Centre for the Study of Pain's Interfaculty Pain Curriculum. Her research is focused on pharmacy practice, opioids, and cannabis use for chronic pain. Welcome, Dr. Sproule and Dr. Murphy. Dr. Sproule will be beginning our presentation this afternoon.
Great, thank you. I'll just share my screen. Okay, thank you. Thank you for coming, and we're happy here to discuss this, this topic that we both have a keen interest in. I'll just start off by indicating that we do not have any disclosures. I'm just trying to see about forwarding my slides here. There we go. And also just to share that by the end of this topic, what we'd like you to be able to do is appreciate the risks of exposures to opioids for acute pain and with long-term use for chronic pain, and to be able to delineate the roles and responsibilities that pharmacists have, in particular in reducing these harms. And so just to kind of set the scene, I just wanted to give you an idea of really that in Canada, we do consume a lot of opioids. And what this graph shows is that over the period from 2000 till more recently, that we really are one of the highest ranking countries in the world for level of consumption. And this shows the increase over the 2000 period in particular. And even though it has been decreasing in recent years, we're still third in the world. And this is out of, over 200 countries, I think they include in this ranking. So we are still quite high in our consumption. And I wanted to show that the relationship between all of this availability of opioids and the associated harms. So what this slide shows is over that critical time period in the 2000s, where the sort of parallel increase in the consumption of opioids, in this case, showing it for the US, but the parallel increase in both deaths due to opioid overdose, as well as admissions for opioid use disorder treatment. And so in Canada, we saw that same increase over that period of time. And that was what we then first saw, what we call our first opioid crisis, which was related to sort of both increases in opioid overdose deaths, but also increases in the harms related to opioid use disorder. And what this slide is showing is the in particular in 2016, that in 1 in 3 of the opioid-related deaths in Ontario had active prescriptions for opioids at the time of death. And for pharmacists, I think it's important to note that the median time between the last opioid dispensed and the date of death was just 4 days. Now, of course, over this past decade, the increase in opioid mortalities had skyrocketed, with the largest contributor being to the sort of toxic street supply with the illicit fentanyl and fentanyl analog contamination in the supply. And also showing on this graph is the number of opioid-related deaths in Canada from 2016 to March of this year. So just phenomenal numbers, both opioid-related deaths and opioid-related poisonings resulting in hospitalization. The chart on this graph shows, though, that even, that confirms that almost 3/4 of these deaths involved only non-pharmaceutical opioids. But I think as pharmacists, it's also important to note that a further 9% involved both a pharmaceutical and non-pharmaceutical opioid, and 17% involved only pharmaceutical opioids. And this would be either both prescribed or diverted prescription opioids. So to just bring it down back to Ontario, what we really wanted to emphasize in this talk is the preventing and the harms from this use of prescription opioids. So primarily in the management of pain, both acute and chronic. And so what this slide shows is just the amounts of opioids that, or the number of people who are exposed to opioids in Ontario, prescription opioids, from 2013 up until 2019. And you can see kind of the gradual decline in both graphs. One is for focusing on immediate release products and the other in long-acting products. And so you can, which is good, you can see kind of the gradual decline in the amounts that are prescribed, but they're still quite high. For the immediate release, the top line is specifically for codeine combinations, and the next highest line is for oxycodone combinations. And then in the lower slide, some slight decreases as well, with the top line being for hydromorphone. So, of course, immediate release opioids are used for both acute and chronic pain. And what I wanted to highlight was the magnitudes higher number of people who are receiving prescriptions for immediate release opioids, where you can see on this scale that the top of the scale is 1 million people, whereas for the long-acting opioids, still a lot of people, but the scale goes up to 70,000. So the immediate release magnitudes higher. And so in my part of the talk, I'm going to focus on the acute opioid, or the acute pain focus and opioid use, and really want to make the case that we're still prescribing large quantities, and yet there's lots of evidence to show that that's really not needed. So on this slide, I'm just showing an example from an initiative from North York General Hospital, where they looked at the amount of opioids that are left over after surgery, and found that there were 83% in fact left over. And so they had an initiative where they created standardized prescriptions for post-surgery that focused on acetaminophen and ibuprofen, as well as limiting the opioids to 20 tablets, but to be dispensed 10 tablets at a time. In addition, they used ISMP Canada handouts that help promote safe storage and disposal. And after their initiative, they found that there were 56% less prescribed opioid tablets in that 3-month period, with no difference in average pain score. And these types of results have been shown in other studies. And at the bottom, I've just highlighted a systematic review that reviewed 6 studies. And they also found that between 60 and 90% of patients reported having leftover opioids post-surgery. Between 40 and 70% of the tablets were actually unused. But that, 3/4 of the people reported that their opioids weren't stored in locked cabinets, and there were low rates of plans to actually have a safe way of disposing of them. So likewise in other settings, so there's been similar evidence in the emergency department and with following dental surgery. So with respect to the emergency department, this is a study out of Quebec where they looked at the rates of prescribing and found that there was a median quantity prescribed of 30 tablets of morphine 5 milligram equivalents. And they found that people were actually consuming less than 10 tablets. And so the advice was that physicians should consider prescribing a smaller quantity, but also ask the pharmacist to dispense them in portions to minimize the unused amounts. Likewise, post-dental surgery, they found that although patients were receiving 28 opioid tablets, there was over half left over. And again, poor rates of disposal. However, in light of that evidence, where there's lots of tablets left over, it's important to note that there's equal evidence showing that they're not needed. And this is a systematic review that was done from the group at McMaster that looked at various types of studies for different types of pain, looking specifically at the benefit-harm ratio of the different agents used. And importantly, they found that NSAIDs, both topical or oral, and acetaminophen had better benefit-harm ratios for the treatment of these types of acute pain. And importantly, their concluding message was that no opioid achieved benefit greater than that of NSAIDs and opioids, and that the opioids cause most harms. So in light of the fact that we are prescribing large quantities for acute pain and that it's not really needed, that there's alternatives that could be used to help with pain relief, there's also evidence of harm. And so I've just pulled a few examples here of the harms or potential harms. And of course, having leftover tablets means that they can be accessed, and there's evidence for student access, in particular in our Ontario student survey, around obtaining prescription opioids for non-medical use from the home is quite prevalent. And what the study here is showing the same thing in the US. And in this case, where 37% of those high school students who endorse past year non-medical use, that they actually obtained it from their own previous prescriptions that had leftover tablets. Also, of course, there's the risk to young children by having opioids in the home, and there's several studies that demonstrate that. And importantly, I wanted to highlight this study from the Center for Disease Control, where they've linked the day's supply of that initial prescription in opioid naive people with the probability of prolonged use. And in this graph, you can see that the day's supply is along the x-axis. And the probability on the y-axis, and even 10 days supply of the first opioid led to approximately a 20% probability of continuing that use long term. And just to emphasize that point, or to put a little bit different angle on it, I wanted to show a bit of data that we have from a study we did several years ago, where we conducted several interviews with people who had opioid use disorder, specifically to prescription opioids, and asked about their kind of pathway to their disorder. And focusing on their first exposures, 217 out of those 349 had their very first exposure to prescription opioids through a therapeutic prescription. Probably not surprisingly, it was most commonly codeine or oxycodone. And the first prescription had fairly large quantities. And almost half of them continued using prescription opioids after that very first exposure through a prescription. And then their continued supply came from a number of sources, including more prescriptions, but also from street purchase and from OTC codeine. So in Ontario, there have been a few initiatives already, particularly related to post-surgical opioid prescribing. And on this slide, I'm just showing a couple of examples here. One is from Cut the Count, associated with Health Quality Ontario, where a number of institutions across the province have instituted specific initiatives within the hospital to reduce the quantities of and other activities around their opioid prescribing. And likewise, recently, there's been a guideline put out around prescribing pain medication at discharge from a best practice in surgery group that specifically looks at safer prescribing post-surgery. So what's the evidence for a pharmacist's role or pharmacists having impacts in this space? And from what we could find, there's just a few examples in the literature to date, but they were all promising. And this slide shows 4 of these. Primarily, three of the 4 are all, again, post-surgical examples, and the 4th one is around dental practice. All of them involved a pharmacist or pharmacy services around working with patients to either reduce their opioid load, opioid dosing prior to discharge from hospital after a surgical event, or following them after discharge and providing education and kind of monitoring their opioid use. And all of them showed that it did decrease opioid use following surgery, usually with kind of a pre-post design or control group, as well as, importantly, showing no difference in pain score outcomes or various pain-related outcomes. So there were similar clinical outcomes with reduced opioid use. So in Ontario, we have a standard for opioid, specifically for opioid prescribing in acute pain. And there's a number of key recommendations in this document. But in particular, we've pulled out kind of 7 key messages that are particularly ones that pharmacists could action. And we divided them into 2 sections. One is assessing the prescription and the other is counseling the patient. And so with respect to assessing the prescription, some key things that pharmacists can help promote is that the concept that opioids are not always indicated and encouraging the NSAID acetaminophen options for acute pain. That daily dose limits should be kept below 50 milligram morphine equivalents. And it's surprising that how many tablets, especially if sort of a common SIG is 1 to 2 tablets, Q4 to 6H, in one day for most opioid tablet sizes and strengths, that would take people over this 50 MME daily dose limit. And this is particularly for opioid naive patients. Also, the guideline recommends safe quantities and indicating that for most sort of primary care or ED related or post-surgical events, that 3 to 7 days is probably enough. And there are some exceptions for some types of surgeries. Also with the important to look at the appropriateness of the product, and they recommend using low potency opioids, so not hydromorphone, for example, where possible, and also to use immediate release and not long-acting or slow release products. And then also it's important to look at people's prescription history to look at related risks. And then also to be able to counsel the patient on both the benefits and risks of the opioid use, and of course promote safe storage and disposal. So translating those guidelines, that standard and the recommendations in that into practice can be a challenge. And you probably noticed that none of the previous studies that we looked at involved community pharmacists. So I just wanted to highlight a study that we have ongoing at the moment, which is sort of leveraging community pharmacists that are dispensing these opioids for acute pain, regardless of where the prescription originated, whether it was from hospitals for post-surgery or from EDs or from dentists or from primary care docs, that the common denominator is where they get them dispensed. And so we think that pharmacists can have a role, particularly focusing on those 7 areas that I highlighted on the last slide. However, it can be a challenge to just implement those. For example, what is a 3 to 7 day supply? And so what we've done in the context of this study is developed a series of e-learning modules and tools and resources that help with implementing this activity into community pharmacy practice to help with the safer dispensing of these opioids. Right now, these tools, modules and tools are available in 5 randomized regions in the province. After 6 months, what we're going to be doing is looking at the narcotic monitoring system prescription data to look at the opioid quantities and doses in these regions and compare them to other regions in the province to hopefully be able to demonstrate the impact that community pharmacists can have. And the poster you see on this slide is just one example of one of the tools that we also developed. So in conclusion, and for my part, I just wanted to indicate that, all of these activities that we've talked about can come under the umbrella of opioid stewardship. And I think that ISMP Canada has a really good definition for this, which is that it may be described as coordinated interventions designed to improve, monitor, and evaluate the use of opioids in order to support and protect human health. And so pharmacists really do have a responsibility in promoting effective opioid use, preventing the development of harm such as opioid use disorder and mortality, but also more broadly in the opioid sphere, have responsibilities in promoting the treatment of opioid use disorder, and in particular, really focusing and addressing the stigma, the issue of stigma, and really looking at their own practice and educating themselves on what more they could be doing to help with this problem. All right, so now I'd like to I'll end my screen sharing and pass this over to Laura.
Just unmute myself there. Thanks so much, Beth. And I'm going to continue with a focus on the safer use of opioids for chronic pain. So I'm going to start here with a brief story about Alice. Alice is a patient living with chronic pain just to illustrate the opportunities in Alice's journey for pharmacists to play a key role on her team in her chronic pain and opioid management. So Alice has used opioids for her pain for many years, though she doesn't feel like her pain is taken completely away. She really does feel like they help her to do the things that she enjoys, and she has regular interactions with her pharmacist to share that information. During COVID-19, Alice's pain has gotten a lot worse. She can't do as much activity and she feels really isolated. She's needing a lot more medication. She's a patient at a family health team, and she likes to see her doctor virtually. This is very similar to what a lot of patients report to me. So she hasn't really had interruptions in her care or her medications, but she's really starting to feel afraid that her pain is getting much worse. She also interacts with the pharmacist in her family health team related to her refill prescriptions. So the worst thing that's happened recently is that Alice fell and she fractured her hip. In the hospital, she was switched to a long-acting opioid and discharged for a prescription for a 1-month supply. Her new morphine equivalent dose is now much higher than what she was previously using, and she'd really like to cut back, but whenever she tries to on her own, her pain is unbearable. So I'm going to leave Alice's story just in the background there. Not only is there an ongoing opioid crisis in Canada, there also remains a chronic pain crisis. 1 in 5, or 20% of Canadians, and up to 50% of the population, depending on the subgroup that we're talking about, experience chronic pain, with women, children, Indigenous people, older adults, veterans, and people who use drugs disproportionately affected. These populations are more likely to experience social inequities and discrimination, which actually influence how pain is experienced. Unmanaged pain has significant impact on patients, families, and society. People who experience chronic pain are highly stigmatized, just getting back to what Beth had mentioned related to stigma. The stigma that these patients experience is heightened further when they use opioids or have what we see as common comorbidities with mental health and substance use disorders. Studies have found that clinicians actually find the management of people who are living with chronic pain overwhelming, and they feel that their education is lacking. And there are gaps and challenges in the healthcare system to manage chronic pain that have been well described by the Canadian Pain Task Force reports recently. And though increased prescribing for chronic pain made significant contributions to the present opioid crisis, this is a really complicated relationship between these two crises, because now this response to the opioid crisis is having unintended negative consequences on those living with chronic pain and their ability to access opioids. Opioids and non-opioid medications are really only one modality that need to be considered in the biopsychosocial model of chronic pain. This model views chronic pain as a multidimensional approach with biological, psychological, and social factors that influence each other. And just a note on the current challenges that are facing all of us with the COVID-19 pandemic. You know, the feeling is that they only draw attention to health disparities in Canada, as in many other countries around the world. And this is an excellent article if you're interested in learning more about this, that was published very recently. Systemically and structurally marginalized populations were noted, including those with chronic pain and those living in poverty, to be disproportionately affected by COVID-19 based on the data that we already have. And in turn, it's noted that the pandemic has further fragmented care for people living with pain and worsened mental health, which can, of course, in turn, worsen that experience of pain. Sadly, it's also important that we note that there has been a recent spike in overdoses and deaths related to substances. So overall, the use of opioids for chronic pain needs to have a balancing act of benefits and risks. On the left of the slide here, I've listed potential benefits patients may experience, including pain relief and improved function. There's also considerations of cost and coverage. Opioids in general are not expensive and are covered by most private and public drug plans. Accessibility I've placed in the middle here because in recent history, they've also been generally quite accessible to patients with some exceptions. Though, as I mentioned, this has shifted somewhat with the actions to address the opioid crisis and may again be shifting back in the context of COVID, where we have limited access to other modalities because we are isolating or quarantining to different degrees. So as I mentioned, people who use opioids also experience stigma. as pharmacists, we need to be particularly aware of how our language matters and can contribute to this stigma. A key approach that we need to take is a person-first language. For example, instead of calling someone an opioid user or a chronic pain patient, we really try and put the person first and say person who is using opioids. Another example would be if we're describing urine drug screening results. Historically, people have described them as coming back dirty if they have something unexpected. And so instead, we should really just use the word unexpected before laying additional connotations on top of those results. The other downsides that I've listed here on the right side of the slide may include long-term consequences such as impacts on mood, immune function, bone health, and sleep apnea. Physical tolerance also develops quite quickly with long-term use. And hyperalgesia can also develop, making pain making opioids less effective and pain worse instead of better. There's also the concerning risks of opioid overdose, and this is of course higher if the patient is using concurrent benzodiazepines and other CNS depressants, and the risk of opioid use disorder. The Canadian opioid guidelines in chronic non-cancer pain were most recently updated in 2017. And Beth and I and a group of pharmacists published a pharmacist framework for the implementation of these guidelines, really to support the translation into pharmacist practice. Later, with a group of pharmacists from across Canada, we put together this guidance article related to opioid tapering, recognizing that the expertise pharmacists can offer the team and the patient to support them to make this decision to taper and then proceed with the taper in a safe way. The Ontario College of Pharmacists also recognized this need for pharmacists to play an active role in management of opioids and outlined an opioid policy. It's important to note that this is the only policy that they have that's specific to a class of medications. Similar to the Health Quality Ontario standards that Beth presented for prescribing in acute pain, there are also those available for chronic pain. Though not specific to pharmacists either, they can help shape priority areas in our practice, including the things I've listed here. And they can reinforce an important role we can play on the team, in particular related to use of data available through the narcotic monitoring system and Connecting Ontario where it's available. So diving a little bit deeper into the pharmacist role supporting people living with chronic pain and using opioids, there have been several studies and 2 meta-analyses that I identified reporting on outcomes from these different types of roles. So I've grouped them here into 4 key areas of focus, which include pharmacist-led chronic pain and opioid management clinics. And these studies were where pharmacists actually had delegated prescribing authority and were able to act independently to support patients who are using opioids. There are also community-based medication reviews for patients with chronic pain that are described, pharmacist-led education for patients, and also opioid risk assessment and screening initiatives. I've listed here some of the outcomes associated with these services that are reported in the literature, and they've included both improved pain outcomes, reduction in aberrant behaviors and adverse drug reactions, improved patient satisfaction, and in the case where pharmacists had delegated prescribing, they also had cost savings, significant cost savings to the healthcare system. So despite this evidence supporting the role of the pharmacist, studies here in Ontario have still they've pointed to some gaps in enabling pharmacists to take on these roles. In 2016, there was a study by Patel and colleagues that found pharmacists lack knowledge to support them in the role managing chronic pain. And in 2020, there was a follow-up qualitative study from the same group, including some other authors, to Beefer and colleagues, that identified barriers that pharmacists had described from their experience caring for people with chronic pain in the community and in primary care. Things like patient finances, the inability to access multimodal treatment options, and gaps in their own training. Other studies have reported that pharmacists are really unclear in their roles and responsibility to address opioid use and risks. And some additional barriers included a lack of available clinical information similar to other chronic disease management, but also discomfort in policing high-risk prescribing. This is in contrast to what studies who have listened to what prescribers have to say, who often regard the role in mitigating opioid abuse or risk and chronic pain management positively. So I'll segue here to say that there remains some room for improvement. Just to move forward with the ROOM tool, the Routine Opioid Outcomes Monitoring Tool, which is a brief 12-item screening tool that was originally designed for patient self-complete to help pharmacists monitor clinical outcomes and assess potential development of opioid use disorder with prescribed opioids for chronic pain. So I've been working with a team here at UHN, Beth's involved too, to implement this tool for clinical use at the 5 outpatient pharmacies we have here. So here I've provided an example of this tool. You can see that there are domains to measure pain at the top, as well as indicators for risk of potential opioid use disorder. And these validated screens then prompt pharmacist actions or referrals with templates to share this information with prescribers. Other screening domains that are included, you can see, are depression, risky alcohol use, as well as constipation. And there's also an assessment checklist that we've included related to important checks the pharmacist should complete when dispensing an opioid prescription for chronic pain. So related to the implementation of this tool, we have several research projects in progress, including a review of completed tools here at UHN, as well as gathering perspectives and feedback from pharmacists, patients, and prescribers who have experience with the use of this tool, with the ultimate goal to optimize the tool and the formatting and promote it for use more broadly. This is a tool that was developed and already implemented in Australia, and so we're really adapting and building on that for our setting. And then finally, just to highlight some research we're doing in other settings, I just wanted to provide a brief overview of our AWESOME study, so opioid stewardship to optimize patient outcomes. At Toronto Rehab, many of our patients, it turns out about 50%, are using opioids for the management of acute and chronic pain, and sometimes both. We have pharmacists here embedded on interprofessional teams, and following the approach that every pharmacist is an opioid steward, in 2017, connected to the release of our Canadian opioid guidelines, we reinforced the existing practice by including calculation of morphine equivalent dose and use of the opioid risk tool. So then we reviewed 448 patient charts with the help of many pharmacy students, I'm happy to report, to extract information about opioid doses on admission and discharge from rehab and practices associated with opioid stewardship. And what we found was that about half of our patients with admission opioid orders had some decrease in their dose during their rehab stay. 1/3 decreased their dose by over 50%, which is usually, or 50% or more, which is usually clinically significant. And 1 in 5 patients stopped their opioids by the time they were discharged. Using a regression analysis, a decrease in morphine equivalent dose was more likely seen with the longer the patient's length of stay and less likely if they had been started on a long-acting opioid in acute care. Tying some of this data back to what Beth introduced about quantities, we found that at discharge from rehab, there might be some opportunities still to reduce quantities, with almost 30% of patients receiving PRN doses that would likely last longer than 7 days, and about 10% of patients, the circle on the bottom right, who received scheduled opioid prescriptions for greater than 30 days, which is beyond what we generally recommend here in practice. But it's important to note that this data doesn't separate patients with acute pain only from people who have underlying chronic pain. And so we really need to assess these practices across programs, and also look at reflections on individualized approaches for patients to avoid interruptions in therapy. So our conclusions from this study were that current practice of opioid stewardship by pharmacists on the interprofessional team results in dose reduction for almost half of all patients admitted to Toronto Rehab on opioids. And we also have a plan to look into opportunities for earlier intervention and discharge planning related to opioid use, particularly when patients are admitted for shorter stays. And we're also looking into opportunities to avoid new starts of long-acting opioids in acute care. So I wanted to acknowledge the many people and students who are involved in these research projects and the groups who have provided funding in support of that work. And I'll end with some key messages. So pharmacists should be proactive and patient-centered to support safer use of opioids as part of an overall approach to pain management. We encourage pharmacists to collaborate with the interprofessional team, because that's where the best evidence is, to support the biopsychosocial model of chronic pain. Really, we'd like to see the management of chronic pain move into the realm of chronic disease management. Pharmacists should practice opioid stewardship with a balanced and rational approach and decrease barriers for patients by providing opioid agonist therapy services and offering naloxone kits as standard of care. We also need to pay attention to the language that we use so that we're not contributing to the stigma that people experience, and ultimately take responsibility to ensure that guidelines and standards are followed. And with that, I will say thank you very much for your attention, and I think we're happy to take any questions.
Yeah, so please feel free to put your questions into the Q&A section, and we'll see about addressing them.
I'll read out the questions, and then we'll see who's the best person to start answering them. So there's a first question from Shelley. How can pharmacists facilitate patients to build up the areas of mind and movement? Shelley mentioned that she doesn't feel she has expertise to do that. So I'll start to answer that question because I believe that came up from my slide. So in terms of mind and movement, the best place to start is to link with other community resources. I think that it's really helpful to have a team where we can consult with in order to help us be aware of important modalities. One chronic pain disease or diagnosis that I can think of where this applies most is with fibromyalgia. And so if we start by asking patients about their chronic pain and about their diagnosis in order to understand the etiology of it, then we can make sure that we can direct people to appropriate resources, knowing that, for example, in fibromyalgia, medication is really not at the forefront of helping people improve their function. And then if we have other community resources that we can reach out to, chiropractors, physical therapists, their family physician, that we can make sure that they have the other supports that they need, that can be very helpful. In terms of us acting as the key resource, certainly we can provide general guidance, just as we would in other chronic disease state management, related to diet, for example, and sleep hygiene, lifestyle factor modification. But it is important that we recognize we're not experts in those areas, and so we can reach out to them. There are also very helpful pain references and resources. RX Files has a very helpful chronic pain management book that's available online, I believe. And the Canadian Opioid Guidelines also has helpful resources related to movement and mind-based therapies and the evidence for those. Okay, so I'll read the next question from Les. In regards to the room tool, how did you determine which information would be included? For example, constipation and depression. And are we referring to Canadian product monographs at all? So Beth, maybe I'll let you answer that because it was actually Beth who introduced me to the room tool to start.
Yeah, so as Laura, it's a good question. So no, it wasn't really referring specifically to any sort of product monograph. It was more the group in Australia that Laura mentioned who developed the room tool, led by researcher Suzanne Nielsen, who's a pharmacist researcher in this area. They, over several years, they conducted a number, like sort of a series of studies determining what items were most helpful in detecting potential problems with people using opioids chronically. And so the items that are in the tool were the ones that kind of performed the best in being able to detect the key issues that they wanted pharmacists to. And they did a number of studies with the different parts of it around related to opioids, or related to some mental health questions, or related to some physical aspects. And then they've have done some work in implementing it broadly into community pharmacy settings. And their project, again, was sort of larger than what Laura has been able to do at UHN to date, which was integrated into community pharmacy software. You know, people were getting get a tablet to kind of complete the room tool, and some information would automatically go back to the pharmacist who was dispensing the opioids. So so that just gives you a bit of background on how the room tool was originally developed and is being studied in Australia, and just being adapted for this kind of university, hospital, community pharmacy setting.
Thanks. So we have another question from Ravinder. Why does it matter which opioid we use? Dr. Sproule said to use low potency opioid, but for example, if 6 milligrams of hydromorphone is equivalent to 30 milligrams of morphine, does it matter as long as, I think she's meaning, as long as we keep that to the minimum morphine equivalent dose? So Beth, did you want to address that?
Sure, and I think that is a good question. I think just with the higher potency agents, the tendency is to still prescribe the same amounts, and so the sort of to keep it's much more difficult for in the treatment of acute pain to keep below 50 MME using hydromorphone tablets compared to other agents, but this was a kind of a consensus-based process in developing that guideline, but it's just more a matter of being able to keep the overall kind of opioid load in a more reasonable framing than using the more potent hydromorphone tablets, which, as I say, it's very difficult. It doesn't take very many tablets at all of hydromorphone to get above the 50 MME. And that's one of the resources that we've put together as part of our study is a table that helps pharmacists see just how many tablets of the different products would keep you below the 50 MME.
And if I can just add on, I think as pharmacists, we may be aware of the differences in the potencies between these opioids, but anecdotally, when I speak with other health professions, there's not always that awareness, and people just feel comfortable, for example, with hydromorphone because the actual numbers in the milligrams are lower. When we frame for people that it's 5 times as potent as morphine, more often than not, patients and other clinicians are quite surprised. And my favorite way of framing that is actually using, commonly prescribed opioids, things like oxycodone tablets, and framing for them, how many oxycodone tablets in a day they would be taking. That's the equivalent of the hydromorphone, and it's often very surprising. So just to add to that there can be that creep and the comfort level with those low actual milligram numbers related to hydromorphone. So I'll move to the next question. Do you think cultural competencies training should be essential for pharmacists? And do you feel this type of training would benefit a pharmacist in reducing the stigma around opioid use? So I'll start, but I'll let Beth jump in at any time. I absolutely think that cultural competency training should be essential for pharmacists, and certainly essential as part of education related to the management of pain, since we see differences from the perspective of health equity. I think that pharmacists in general can really play a key role in reducing the stigma around opioid use, since we have so many touch points in the system related to medications, and we can really be leaders in this, even with our own patients who sometimes use specific language, even talking about themselves. We can help them in that individualized interaction, even promote their own view of themselves by taking away some of that language. I've had patients call themselves addicts, junkies, and without arguing with them or correcting them, when we start to remove some of that language, we really move towards more of a therapeutic relationship, and looking at the opioids as only one tool that they have, and not have control over their own life. So I think both on an individualized and a societal level, pharmacists can play a real role here, and education is the start. I will share that we are including a focus in the interfaculty pain curriculum this year on these very issues. I'm really proud of that. And I'm hoping that that will spread to other education as well. So I'll move to the next question. Do we have a resource to help PTs find or be referred to PTs, physiatrists, or other outpatient physical therapy specialists? This viewer has had PTs ask for help. They've also had situations with physical therapists going to chiros or other alternative health practices and getting less than evidence-based advice. So I don't have it on the tip of my tongue, but there is a resource available to help identify local physical therapists. I came across it through the Canadian Pain Task Force. And so if you'd like to email me that question, I'm happy to email back that link. I believe that there may be one housed on the McMaster site for pain, but beyond that, you'd have to go to the college. I think that, in the situations, though, that you mentioned about, going to chiropractors and including maybe alternative health practices and things that are less evidence-based, I think that we really need to be patient-centered in that approach. So, maybe we don't necessarily refer them on to practitioners that we're not familiar with their practices, or we don't know how they would help them. But I think we can educate ourselves, and like I said, make those connections in the community so that we can make referrals to people we trust. But on the other hand, if patients themselves are seeing these types of practitioners or trying these practices and receiving a benefit, again, back to that biopsychosocial model, I think we do need to respect that and just work towards ensuring that there's not, interactions with other modalities, including medications, and that there's not harm actually occurring for that patient. So I'll move on to that next question from Anthony. For patients on opioids for months at a time, should patients switch opioids so they're not on one opioid all the time? So maybe I'll ask Beth to start there.
I actually think you're probably better positioned to do that from your work in the chronic pain clinic in particular.
Okay. Sure. So, when I think of this question, it's really about the development of tolerance. And certainly we know that patients can develop tolerance to one opioid over time. And sometimes it's helpful to help keep their morphine equivalent dose low instead of increasing the dose to do an opioid switch or rotation. So in the Canadian opioid guideline, there is a recommendation that if people still are experiencing unmanaged pain, that an opioid rotation may improve their pain and also decrease their morphine equivalent dose. And so we do recommend that, but I don't see, you know, routine switches happening, for example, in a year or year to year, because we're commonly overlooking, you know, what is the opioid in general doing to support this person's pain and function. And sometimes the decision is not to continue opioid therapy, but actually reduce it and trial stopping it, or change other therapies, like non-opioid therapies. So in cancer pain, for example, I know that they do routine opioid rotations more frequently. For us, it's usually a means to an end, like a goal to either reduce their morphine equivalent dose or improve their pain as a trial. And then many people actually do not have opioid responsive pain, and so they would continue to reduce and trial off of it. And so the next question, do we feel that pharmacists have a role or opportunity to reduce the use of highly addictive medications, such as opioids?
So yes, a big yes. I do think that pharmacists have certainly the opportunities and definitely a role to be vigilant in helping reduce the risks of people developing problems to medications that are known to have the propensity to cause addiction-related harms. And I think that opportunity is, you know, much of what we've been talking about today around just being aware of what the appropriate place of opioids are in both acute and chronic pain, as well as for those who are using it really for acute or chronic pain, understanding the situation and understanding your patient and what their individual risk factors may be, and monitoring their therapy throughout to help make them aware and be able to detect early if there are any problems of that nature arising. And that is, yes, for whether it's for opioids or for benzos or for the medical use of cannabis. I think for all of these things that are used therapeutically and people are exposed to them therapeutically, it's definitely something that needs to be in our routine monitoring approach for these types of therapies.
Great. I knew that was the right one for Beth to answer. And so I think this will likely be our last question, as we're past the 5-minute mark before we end. So as the government has taken steps to improve access to treatment services, what are some of the ways pharmacists are adjusting their model of care? So I'm not sure if this is in the context of COVID-19. So maybe I'll start with that approach. You know, in terms of access to pharmacist care, certainly in the hospital, in our specialty pain clinics, in primary care, a lot of pharmacists are doing a lot of their work virtually, and, you know, offering appointments either through, you know, Connecting Ontario's video conferencing services or by phone to keep in contact with patients. I know that our outpatient pharmacies here are doing a lot more follow-up by phone when they're delivering opioids. And I think the question might be related to, you know, improving access to treatment services where the legislation has actually changed and pharmacists can take now verbal prescriptions for opioid therapy and have some other enhanced practice. Beth, did you want to add anything else right before we close?
No, I think that was great. And I also think that we're out of time, actually. So So thank you everyone for joining us today, and feel free to reach out to either of us if you have further questions. Thank you.